Good morning. Thank you for the invitation. Looking forward to my presentation on COVID-19. So what I'd like to start with is COVID-19 is an acronym that stands for Coronavirus Disease 2019. And this is the medical condition, the disease that we now have identified as being caused by a coronavirus. The particular virus is SARS coronavirus number 2. And all coronaviruses share the same features. They are spherical. They have these tiny projections that come off of them, and they utilize these projections as a way of attaching to receptors on our cells, as a way of initiating processes that will end up with this virus being inside of the cell and infecting it. Inside the cell itself, as you can see, the spiky projections and the capsule is a single strand of RNA. All coronaviruses are RNA viruses, and this is the material that codes for the making of new viral particles. So what do we know about coronaviruses? Well, we know that there are over 90 to 100 different categories of viruses that fall under the family of coronaviruses, but only 7 of them infect humans. All of the others infect animals. 4 viruses that we know of are responsible for the common cold. So at least everybody who's watching this video, and certainly around the world, most likely has had a coronavirus infection in their lifetime. But since 2012, there have been 3 viruses that we've actually identified that have converted from causing disease in animals to now being able to cause disease in humans. The first one was identified in 2002, and it was named SARS coronavirus 1, SARS standing for Severe Acute Respiratory Syndrome, which was the name of the condition, respiratory infection that was caused by this virus. As you can see, it caused a limited number of cases, a limited number of deaths, but when all was said and done and this virus was eliminated after a 1.5 years of infection, it had resulted in a mortality of about 10%. In 2012, we saw another coronavirus come on the scene. This one was called MERS coronavirus, MERS standing for Middle Eastern Respiratory Syndrome, and it caused the condition we called MERS. We knew that this virus had transmuted from camels to humans, whereas SARS had originally been a bat virus that had mutated into an intermediate host and then subsequently to humans. There were a limited number of cases, a limited number of deaths, but in the end, the mortality was 34%. 1 in 3 people who got MERS died. So when we talk about what's important to be a good virus from the virus's side, what we really want the virus, or what the virus really wants to be able to do, is be highly infectious, easily spread, but not cause a lot of death, because with the death of the host stops the spread of the virus. So in 2019, we identified a new coronavirus, similar enough in genetic makeup to be considered a close cousin of the original SARS. And so it was labeled SARS coronavirus 2. And the disease that it causes is COVID-19. And what we've seen so far is this disease has spread to over 54 million people on the planet. So how deadly is coronavirus actually? Well, when we look across multiple populations, whether it's global, in America, in Maryland, or in Worcester County, we're seeing a pretty consistent case fatality rate. A case fatality means the number of confirmed cases of people who have the disease versus the number of people who die from it. And right now, from the confirmed cases, we're averaging about 2.5% of those people will die from COVID. But that isn't equal across the board. What we do see is age makes a difference. So if you are under 20, the likelihood of dying from COVID is very low at 0.003%. But by the time we get up to 70 or greater, we're looking at 5.4% case fatality. Why we don't actually know how deadly the disease is because we haven't really had an accurate estimation of how many people have been infected by this virus. It is proposed that there is perhaps 10 times greater number of people who have had the infection than there are people who have been confirmed or told that they have the infection. So if we look at the infection fatality rate, which means of anybody who gets this disease, what's the likelihood they will die from it? The infection fatality rate for COVID is estimated to be probably going to be between 0.5 and 1%. So comparing it to the flu has a 0.1% infection fatality rate, making coronavirus or COVID-19 10 times more deadly than the flu. But compared to MERS, which was 34%, and SARS, which was 10%, this virus actually achieves what a good virus should. It spreads readily, but doesn't kill as many people. So what is really impressive about it is how readily it spreads. And if we look at a timeline, this just represents 4 months of time. On December 1st, a group of Chinese doctors in the Wuhan province of China reported to their government that they saw a cluster of people who were getting this viral pneumonia, some of them dying, which they had never seen before. The World Health Organization was notified of this, and on the 31st of December, they reported to the world that there was a respiratory infection of concern that could potentially hit, a larger group of people. By January 7th, China had at that point identified that it was a novel coronavirus causing the Wuhan pneumonia. Novel meaning we had never seen this virus before, and we wouldn't expect that anybody would have any immunity to it. By the 20th of January, the first reported case in the United States was reported. By March 11th, the World Health Organization had now upgraded COVID-19 to a global pandemic. On the 17th of March, all 50 states, DC, and 3 US territories had reported cases of COVID. On the 26th of March, the United States took the lead in having the largest number of cases of any country on the world. And that's a dubious distinction that we hold to this day. By April 4th, we reached our first milestone. In just 4 months, we went from a couple of cases to 1 million. So were we taking these cases seriously? I don't think so. So what do we want to know about the infection? How are we getting it? Well, what we do know about all coronaviruses is they are respiratory infections. People who are infected through the moisture in their breath when they talk, or the secretions when they sneeze or cough, will spread material that contains in it the viruses. Those floating in the air will be inhaled through our nose or mouth, or if they land on surfaces, become what are called fomites, meaning they are infectious particles that if then touched and transmitted to our hands, by us touching our eyes or nose or mouth, we then bring the virus into our body. We do know specifically that the COVID-19 virus attaches its spikes to receptors on our cells called angiotensin II receptors. And what's important about this is these ACE2 receptors are distributed everywhere almost in our body, but are particularly plentiful on the upper and lower respiratory cells of the nose, mouth, pharynx, and lung. And as you can see in this picture, which is an electron microscopic picture of the virus, the corona or crown, corona is Latin for crown, that the coronavirus has are the spiky projections. Then there's the capsule of the virus, the nuclear material inside, and this picture is actually showing this virus attempting to attach to receptors that are located on the cell in order to infect this cell. So just very quickly how it does that. All viruses do this as well, but in particular for COVID-19, this virus will attach to the ACE2 receptor, which starts a series of processes that will bring the virus into the cell, infecting it. The capsule will then break open, allowing the nuclear material to be released into the cell, where it will hijack the manufacturing process of the cell, the endoplasmic reticulum and Golgi bodies. They will then be instructed to create more viral proteins and nuclear material to create more viral particles, which will then be carried to the surface of the cell and be released, for them to go forward into the tissue and into the bloodstream to infect more cells. So if you do get this infection, what can you expect to have happen? Well, 30 to 40% of people who get this infection will have no symptoms. So that's a big problem, because they are still going to be infectious to others, but they will not know that they have the disease. Of the people, 60 to 70% who are going to have symptoms, 80% of them will have mild symptoms, meaning no cases, no evidence of pneumonia, or very mild symptoms of pneumonia that can be very easily managed on an outpatient basis. Only 15% of people who get this will have severe symptoms of shortness of breath and a drop in their oxygen that will require admission. And 5% are predicted to have critical symptoms leading to respiratory failure and other organ failure that will require an ICU admission, and from who we obviously see the largest number of deaths. So what is it that would make a person have severe or critical disease? Well, we've identified some risk factors, and this isn't comprehensive because there's still more research that needs to be done. But as my previous slide showed, the older we are, the more risk we are of having severe disease, particularly over 70. Being male is a higher risk, and having what's known as comorbid conditions, other medical issues which impair the immune system, can make you more likely to have a severe or critical case, including diabetes, high blood pressure, heart, lung, or kidney disease. We've seen higher risk cases for people who are obese, who smoke, who have any immune compromising condition, including cancer. And there may be some genetic factors that actually make an individual more likely to have severe disease. One proposed is blood group types. That type A blood group may be at higher risk for having severe cases of COVID. That's still being evaluated. The other is interferon. This is a substance we all release that communicates with our other cells when one of our cells is infected. So it's a way of sending out a message to ramp up the immune system and help us fight it, because we've identified infection. Black, Hispanic, and Southeast Asian Americans have a disproportionately higher rate of death. And while there may end up being some genetic or important differences that we need to identify between different demographics, in general, so far, what we've done is, when we make all things equal, we don't find any one specific thing to explain why this should be the case, other than the likelihood that our Black, Hispanic, and Southeast Asian citizens are having a greater difficulty in gaining access to medical care, and are having a greater difficulty in having their comorbid conditions well controlled. That I believe to be an indictment of our healthcare system, and why it is important that we protect and find a way for healthcare to be available for all of our citizens. So the takeaway point from this is mortality rate is between 10 and 12 times greater for an individual who has comorbidities than for someone who does not. So where are people getting this infection? And what we've identified is mostly from households. People are bringing it home to family and friends. 53% of people who live with a COVID positive family member will be infected within a week. Now that does mean that 47% don't. So if you think you've been exposed, or you have a positive test and know you've been exposed, please protect your family members with all of the protective measures that we recommend, and that I'll talk about on future slides. Because it isn't necessarily a done deal that if you have it, they have to have it. It is primarily the indoor close-quartered settings that we have to avoid. And everyone is familiar with offices, restaurants, bars and clubs, church cruises, and food processing centers. Mount Air up in Delaware had a case. We've had it, spikes in jails. When we're together, breathing, coughing, and sneezing on each other, we spread this infection. Outdoors in general is considered a safer place to be. However, if you're outdoors and still in a crowded setting, particularly without mask wearing, you may still be at risk for contracting COVID. So the CDC has tried to come up with a definition of what's considered a risky situation, and we've identified it as close contact. So if you are within 6 feet of an individual who subsequently is COVID positive for greater than 15 minutes over a 24-hour period, you are considered to be a close contact and at higher risk. So what does 15 minutes over a 24-hour period mean? Well, if you're in an office, in a cubicle, and you have a colleague who's 10, 15, 20 feet away, but he comes into your cubicle space and talks to you for 5 minutes and leaves, but then comes back later and talks to you for 10 minutes and leaves, and then comes back at the end of the day and talks to you for another 5 minutes and leaves, you now have had 20 minutes of exposure over that 24-hour period. And if he's been within 6 feet with proximity, if he becomes positive for COVID, you are now considered to be one of his close contacts and you are at risk. So why is it important for us to pay attention to the close contact? Well, what we've identified is the power of social distancing. Now, please don't focus just on the days or on the numbers, because this data does come from March of 2020, and there has been some changes. But in general, from a study done in China at the beginning of the infection, what we identified was that one person with COVID was very likely to infect 2 to 3 other people. And that would give you an average of 2.5. With 2.5 people being infected over a 30-day period, you could see hundreds of people being infected from that one individual. If we decrease exposure by 50%, you can see what a dramatic improvement we have in decreasing the spread. And if we decrease it even further by 75%, we could actually reach a point where we could control this virus and get COVID, the epidemic of COVID under control. And as you can see, because we haven't been as conscientious about following the rules, we have never reached a point where we've been able to get our COVID cases down. And in fact, every time we have a spike, we've started from a higher point than we did previously. And each time the numbers are just going higher and higher. So what is it about COVID compared to other infections with coronaviruses that make it so difficult for us to get a handle on? Well, it has a lot to do with how this infection progresses once we have it. There is such a thing as an incubation period, and that is the time the virus enters your body from the time you're going to present with symptoms. And that incubation period is the time that on that graph where the virus is coming in, being replicated and going out, infecting more cells, going in, being replicated and going back out, where we're building up the level of virus in our body. The incubation period for COVID-19 will be anywhere between 2 to 14 days, but on average, if you're going to have symptoms, they will probably present within 5 to 7 days of exposure to this virus. Well, if you were infectious at the time you got sick, it would be very easy for us to say, if you're sick, stay home. And then by isolating yourself, you would not be spreading it to others. But this is the unique thing for COVID-19. For approximately 2 to 3 days before symptoms start, you are still infectious. You will be releasing through your breath, through your mucus, with coughing and sneezing, viral particles that other people can inhale that will infect them. This is called the pre-symptomatic but infectious period of COVID. And that doesn't even take into account the 30 to 40% of people who will go through this whole line but not have the signs or symptoms. They'll be asymptomatic but still spreading infection. So it's the people who do not know they are infected who are driving this pandemic because they are spreading it to others before they know they're sick. So if you do get this virus, what are you going to expect? If you do get the symptoms of this virus, what would you expect to have? Well, the symptoms haven't changed very much. We recognize, because we have ACE2 receptors predominantly in our respiratory tract, this infection is going to be a respiratory virus. Most people will present with a dry cough, with a fever, and with shortness of breath or difficulty breathing. Loss of taste and smell has been strongly associated with COVID-19, but very few people actually get that symptom. So the bottom line is there are no specific symptoms that confirm COVID. You could have your allergies or a cold or strep or the flu, or it could be COVID. So it is important for us to be paying attention to when you think you may have been exposed to people, and if you develop any symptoms that may be suspicious for COVID-19. So if you do think you may have been exposed and have it, what ways do we find out for certain if you do? We have 3 different types of tests, but what's important to recognize is none of them are perfect, and we can't hang our hats consistently on the results. The first one, nucleic acid amplification test, or the NAT test, is the preferred test. It can be given to someone who has symptoms or does not have symptoms yet of COVID for testing. It requires a nasopharyngeal swab. We put a swab into the back of the nose to collect infected mucus, and it's sent to the lab and takes about 2 to 5 days for us to get the result. This test amplifies viral RNA, the genetic material, if it's present. And if you get a positive test, if it's identified that we see the genetic material of this virus and you are tested positive, you can be fairly confident that that means you actually have the disease. But unfortunately, due to that incubation period again, a negative test may or may not be sufficient to prove to us you don't have the disease. And false negative rates are a concern. If on the day you are exposed or infected with the virus, you get a test, there is a 100% probability the test will tell you you don't have the disease when in fact you do. 5 days after your exposure, it drops to 38%, meaning 1 in 3 people approximately will be told they don't have the disease when in fact they do. And 8 days after exposure, 1 in 5 people will probably be told they don't have the infection when in fact they do. So the recommendation for this test to be the most sensitive is 5 to 7 days after exposure. If you get a negative test, it may be sufficient to rule out the disease. But what's of most importance is if it's positive, you can feel fairly confident it really is positive. The second test is the rapid test. It also looks for the genetic material of the virus, but it doesn't amplify it in any way. So it is much less sensitive and much easier for us to have a high false negative rate than with the NATS test. This test was always meant for people with symptoms. It is being used, and we are testing people without symptoms with the rapid test, but it only has value if you test positive. A negative test should not put you at ease that you absolutely don't have the infection. Because again, if it was too early and you didn't have enough virus to make the test positive, it could mean 3, 4, or 7 days down the road, you then will be infectious to people and were told improperly that you didn't have the infection. This test is meant to be done 5 to 7 days after the onset of symptoms. So the NAT test can be done 5 to 7 days after exposure, but the rapid test really is its most reliable 5 to 7 days after you start having symptoms consistent with COVID. The third and final test we have is an antibody test. In response to viral infections, we do produce IgG antibodies. And these antibodies are meant to be the sentries that float through our bloodstream and are there as sentinels to protect us from future infection. They're produced naturally within 1 to 4 weeks of exposure to a viral infection. So when we do the antibody test, we're not trying to determine if you have the disease, we're trying to determine if you had the disease. It is unclear, unfortunately, how long the immunity may last. At this point in time, we are fairly confident that at least 3 to 6 months after infection, you should have measurable IgG antibody levels. However, possibly after 6 months, there may be waning of immunity, and there may be a point at which we no longer can measure antibodies. The other thing that may happen as well is viruses mutate. And so you may develop antibodies to the first version of the coronavirus that causes COVID, but 2 or 3 iterations later, after this virus is mutated, the antibodies may no longer be able to detect the virus and be effective against it. So the CDC has come up with a series of recommendations. If you think you may have it, what do they say you should do about it? Well, the recommendations are if you have symptoms for COVID and your symptoms are mild, you should be tested. And in every acute care clinic in our area and in a number of pharmacies, they are testing with the NAT test. Many of them are also doing the rapid test as well. But if a rapid test is done, the backup NAT test should also be done to confirm. It is recommended, if you have symptoms of coronavirus, that you isolate for 10 days after the start of symptoms. This is the natural progression. The incubation will be 2 to 14 days, but once you develop symptoms, if the disease is mild, you are probably infectious for up to 10 days. And after 10 days and 24 hours without a fever, without the use of Motrin or Tylenol, you are probably no longer infectious. Please know that isolating yourself and wearing a mask and hand washing is still important to be done with family members who may not have contracted the infection from you and from anybody else that you would come in contact with outside your home. If you test positive and you are isolated for 10 days and 24 hours you've had no fever, you don't need to retest in order to return to work. You can feel fairly confident that after 10 days of mild disease, you are no longer infectious to others. If you have severe disease or critical disease for which you are hospitalized, your isolation period may be much longer than that because the ability to continue to spread infection has been shown to be longer as well. But what if you don't have any symptoms of COVID, but somebody tells you that someone you came in contact with is COVID positive? Well, that's when we go back to the close contact definition. If you have been within 6 feet of an individual who's tested positive and spent at least 15 minutes or greater within a 24-hour period in close contact with them, you probably should be tested for COVID. Please know, because of the incubation period, if you don't have symptoms yet, we don't know where you are along in that timeline of 2 to 14 days. So it is recommended that you isolate for 14 days so that you don't go into that pre-symptomatic period where you don't know you have infection yet, but you are spreading it to others. Please limit your exposure and wear a mask and wash your hands to decrease the likelihood of spread. And if you are a critical worker where you don't have the option of staying home, the best you can do is to make every effort with a mask, with distancing, avoiding crowds, and hand washing to not share your virus with others. If you don't have any symptoms and you have not had close contact, no testing is required. If you are a high-risk person, though, you might want to be tested. And if you talk to your doctor, he or she may recommend testing for you. But please know that, again, if you suspect you could have been exposed to COVID and you or a loved one are high risk, you should isolate while waiting for the result. And even if it's negative, still consider isolating yourself for 14 days to not run the risk of spreading infection. So now you find out you do have COVID. Well, what kind of things are available for us to help you, to treat you? Well, whatever you do, please don't listen to what this guy says. But if you are asymptomatic, what's important to note is if you don't have symptoms, there isn't anything to treat. It is important to stay isolated so that you're not spreading infection. And I would follow, with your asymptomatic state, the 14-day isolation in order to make sure that you've completed the entire timeline and are no longer infectious to others. But if you, or actually, you know you're positive, sorry, with this one. If you have mild symptoms of COVID-19, meaning you don't have pneumonia or you have mild symptoms of pneumonia that we know can be safely taken care of at home, you are welcome to use over-the-counter medications for comfort, for relief of symptoms only. Tylenol, cough syrup, saline. But please be mindful of your immune system. Rest, drink plenty of water, eat a good diet, sleep well, and isolate yourself so that you can get over this well. If you have severe symptoms or critical symptoms, you should probably be admitted to the hospital, and critical symptoms are admitted to the ICU. So we know someone who had severe symptoms. And what did he receive? So he got the entire cocktail of 8 medications and supplements. Dexamethasone is an anti-inflammatory medication or steroid, and it's used predominantly to try to combat what we believe to be the over-response of our immune system that produces cytokine storms. So our own immune system may overreact and produce as much damage as we get from the virus itself. So dexamethasone is being used. Remdesivir is the only medication that's been approved by the FDA as an antiviral for treatment of COVID. Regeneron, which has not been approved yet and is still experimental, is actually recreated antibodies that were obtained from people who had recovered from COVID infections. Pepsid, aspirin, melatonin, zinc, and vitamin D are substances that we are giving to people as a way of trying to manage the complications that we see from COVID. So please know that none of these medicines are recommended if you are COVID positive but have no symptoms, or COVID positive and have mild symptoms. And in fact, many of these things that we're giving to severe and critical people, we don't even have good evidence yet that they make a difference. But we can say with fair confidence that vitamin D, zinc, and even vitamin C, which are known to be part of the substances that help our immune system, may be taken relatively benignly and are unlikely to cause problems. But again, please know the FDA has actually warned companies about overstating the fact that zinc or vitamin D will protect you from COVID or even help you get over COVID when you have it. So what happens after the infection has run its course? Well, we do have this recovery period that we've identified. Even 10 days after, when you no longer have a fever for 24 hours, where we know you're not infectious, you can still have mild symptoms of up to 2 weeks. And for severe disease, you may still have symptoms of feeling poorly weeks or even months after you've recovered. The most common symptoms we're going to see are fatigue and brain fog, shortness of breath, coughing, joint or chest pain, and very rarely persistent fevers. What this doesn't take into account, however, are those individuals who have severe or critical disease that have injury. So if you have a vasculitis that occurs or inflammation in blood vessels that leads to a stroke or heart attack or pulmonary embolism, or there's damage to your kidneys, whatever damage is done, the sequelae you will live with for the remainder of your life. The persistent symptoms that we see here are the ones we anticipate gradually resolving over time. So what is it that our body does after an infection to help protect us? Well, we have in our immune system multiple players, but the primary thing is we do create antibodies against infection. What's unfortunate about coronavirus is the possibility that the IgG levels of antibodies may wane over time. We're fairly confident that over a 3 to 6 month period, they are probably measurable and are probably still protective. And we do see that with more severe infection, you're more likely to have a higher level of antibodies. But there are also cells that help us fight infection. So antibodies tag viruses and tell our immune system, that's a virus or that's a germ, please kill it. But our T cells identify cells of our body that have already been infected and destroy them as a way of stopping them from being able to produce more virus so that the virus can spread. And there is the possibility that even if the antibodies wane, we may still maintain a certain level of protection against the infection by assistance from our T cells. It has been discussed that we should create herd immunity, and in this way, then the virus will die out. And this is true. Herd immunity means that that a virus has difficulty finding somebody who is still vulnerable to the infection, because so many people have had it or so many people are protected from it that the virus can't infect them again, and only a small percentage of people are left who are still vulnerable. The problem with doing herd immunity naturally versus with vaccines is that we think less than 10% of the global population so far has been exposed to COVID. And while COVID is thought to have a mortality rate of maybe 1%, which relatively speaking is a lower mortality rate than MERS or SARS, when you start looking at large numbers of people, you're starting to look at large numbers of deaths. So in the United States, with a population of slightly over 330 million, with a 1% mortality, we would be looking at about 3 million deaths. And that doesn't even include the people who are going to survive, but will be left with permanent damage to their health from the COVID. So herd immunity is always meant to be obtained by vaccine. When we introduce into an individual's body the pieces of the virus to which our body then has the ability to develop antibodies, we can create those sentinels that will protect us from infection without having to have the disease first. Right now, there are over 170 different companies that are working on vaccines, and the first one to the finish line is the winner. Pfizer right now seems to be leading with a vaccine that is already being used on over 30,000 subjects. And the data so far, even Dr. Fauci is pleased. They are predicting between 90 and 95% effectiveness with this vaccine. However, one of the drawbacks of the Pfizer vaccine is in order for it to be packaged, transported, and then administered, it has to be refrigerated and frozen. Whereas Moderna's vaccine, which is touting now between 90 and 93% effectiveness, although in a smaller population of people, so it's behind, it hasn't yet had wide sampling of people. It believes that its vaccine will be stable with just refrigeration, and that will make it much better because there are places in the world where we wouldn't be able to get it if it had to stay frozen. So by producing a vaccine that can stay stable at room or refrigerated temperature, we can get it to more people. So when we look at efficacy of vaccines, if it were possible to create a vaccine that were 100% effective against COVID, we would only need to have 60 to 72% of our population take the vaccine in order to generate herd immunity. If the efficacy of the vaccine drops to 80%, now we're going to have between 75 and 90% of our population have the vaccine in order to generate herd immunity. Well, if Pfizer and Moderna stay in the 90 to 95% efficacy rate, we'd be looking at between 70 and 80% of our population would need to take this vaccine in order for us to get a handle on COVID-19. So while we're waiting for the vaccine, and even after we get the vaccine, what personal things do we need to be paying attention to help slow down the spread of this disease? Well, it's the same as it ever was. We want to continue with social distancing, staying greater than 6 feet away from people who don't share our biome, meaning people in our pod, in our home, who we've been in contact with, who have also isolated away from others, they're safe for us to be in contact with. But others, particularly if they are closer than 6 feet, may pose a risk. Hand washing, still essential. After touching any surfaces or before touching your eyes and face, please clean your hands to not bring the virus to yourself through the formation of fomites. And hand sanitizer of 60% alcohol or greater, or using soap and warm water washing for greater than 20 seconds, particularly between the fingers and under jewelry, is important to make sure that you're not carrying infected secretions on your hands. It's still reasonable to consider limiting non-essential activities, especially indoor or crowded venues. Please consider still the continuation of delivery of groceries or curbside pickup or carry-out dining. Sanitize surfaces so that you don't pick up fomites and have them on your hands, even though it's still necessary to wash your hands regularly. And try, when you have to be indoors, to have a place with adequate ventilation, windows open, so that with air movement, you can decrease the likelihood that the virus stays contained in an enclosed space and you inhale it. And then mask use, mask use, mask use. It is important still. And there have been changes. People have complained about this, and I understand it, but we learn more information, we update what we say to people. That's how science is supposed to work. So what we thought early on was, well, why would masks work? Because the virus is so much smaller than the holes in the material of the mask. But lo and behold, when we gathered enough data, we realized, no, masks really do help. And initially in March and April, we were saying wear a mask because it may not protect people who sneeze or cough on you, but if you cough or sneeze and it sticks to the inside of the lining of the mask, you're protecting others. And that kind of was a problem because we didn't have enough people who cared enough about not spreading infection to wear the mask consistently. Now, most recently, it has come out that not only do you protect others, but you in fact are protected by wearing a mask as well. Exhalation valves on the masks are not recommended. And please make sure your mask fits well so that it's not continually sliding down, because the touching of your eyes, your nose, your mouth, or the continued raising of your mask, it just increases the risk. You're going to bring the virus to your nose and mouth or eyes and introduce the virus to your body. Please know there's no decrease in oxygen or buildup in carbon dioxide with mask use. We're very, very confident of this. Consider wearing the mask inside your own house if you've been exposed and you have high risk, family members, just to prevent the spread to your loved ones and friends. Still wear a mask. But anytime you're indoors, not in your own home, you should have a mask on the whole time. And outdoors, you should still consider wearing a mask if you can't maintain the 6-foot distancing that's recommended. The fabrics that are being used for masks are predominantly is cotton. Dish towel, believe it or not, because it's fuzzy and thick, is actually a pretty good material to use for masks. The secretions and the virus will stick to the fibers, and we're less likely then to draw it through the holes in the material and into our mouth and nose. Tight weave is better. You can actually see almost through burlap, but the tighter the weave of the cotton, the better chance you have that the secretions and the virus will stick to the fibers and not be transmitted through. Double or multiple layers are preferred. Bandanas and gaiters, which are very thin and single layers, are not preferred. Double layer or more is. However, it's a choice between gaiters and bandanas and nothing. I would recommend wearing a gaiter or a bandana. But if it's possible to double it so that you have 2 layers of the bandana or the gaiter, that's preferred. Surgical masks and N95 masks have become an important topic too. If all things were perfect and we had an unlimited supply of masks, of surgical and N95, it would be recommended. N95 is probably the best. It has to be fitted to the face in order to be the most effective. And for many people, wearing that long term is less comfortable than the cotton masks. But things aren't perfect, and we do have limited resources. And so right now, surgical masks should be limited to medical personnel, and the N95s I don't even wear. I want them to be plentiful and available to my colleagues, the nurses and the doctors and the respiratory therapists who are taking care of COVID patients. They are the highest risk of all for contracting and dying from COVID. So a question was asked earlier about KN95 masks, and I went and got more information. The KN95 mask is manufactured, is multiple layered out of China. I don't have any reason to think, if they're following protocols that are recommended for N95 masks, that it wouldn't be just as good as an N95 mask made anywhere else. It's just that I don't know. I don't know if the masks created in different countries of the world follow the same standards. What I do feel is that if you're wearing a good tight weave, double layered cotton mask, you are probably getting adequate protection. Face shields and goggles are actually not recommended except for healthcare workers. It's meant to prevent the splashing into the eyes, but does nothing to protect you from inhaling the virus. So it is never meant that a face shield should replace a virus. Replace a mask to filter out the virus. So this is my friend. I don't know him personally, but he's demonstrating the proper way to wear your mask. It should cover your nose and cover your mouth and stay there and not slide down continuously. So while it is important for us also to be following, personal measures, there are also community measures that are important for us to pay attention to. We've done it before, and we may need to do it again, but stay-at-home orders may become necessary. Businesses and school closures are happening. And in fact, Worcester County Public Schools, as of 4 p.m. yesterday, are now closed due to a spike in COVID-19. We should limit the number of people who gather. It came to my attention that on Halloween, there were greater than 300 high school students who all met together on a piece of property in Worcester County, and that's now been traced back to the COVID spikes we saw in the school. So travel restrictions are important. Aggressive isolation, particularly of people who have symptoms. Once we identify they're sick, you should stay isolated from others. And contact tracing is essential, and that has not been coordinated well enough, in my opinion. People who are going to or returning from high incidence areas should isolate for 14 days because that's the incubation period, and you want to make sure that you haven't brought virus to or back from an area that is high incidence. And if you've never done it before, I am pleading with you, please get a flu vaccine. The flattening of the curve that we talked about early on in the disease was meant to try to limit the overwhelming of our medical resources because they are not unlimited. If we have a huge number of people who have flu and need to be admitted and a huge number of people who have COVID and need to be admitted, we are going to run out of resources, bed space, ventilators, everything else that we need to treat people properly. On top of the fact that people with heart attacks, strokes, or car accidents who present to the hospital previously were not getting the proper medical care they needed because the medical system was just completely overwhelmed. So flattening the curve is still important. Please consider getting a flu vaccine. So I think we can all agree that this was the national strategy for managing COVID with the prior administration. And what I am hoping is that this represents step one of the new strategy for getting COVID-19 under control. Thank you very much for your attention. You're muted to me.
Dr. Gibbs, thank you very much. I know that the Democratic Women's Club really appreciates all the time and practicing and efforts that you put into this. This was just an absolutely fabulous presentation, and we'll be very happy to share it.
Thank you. You know what? I didn't even set a timer. How long did I go? I hope I didn't bore you for too long.
I don't think it was that long. I'm going to stop the recording.